I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Welcome, welcome, welcome to those of you who are able to join us today during our Lung Cancer Living Room. I'm Danielle Hicks, Chief Patient Officer here at GO2 Foundation for Lung Cancer. Tonight we have with us Dr. Anthony Lanfranco, who is the Director of Interventional Pulmonology Fellowship Program, Section of Interventional Pulmonology and Thoracic Oncology at the University of Pennsylvania, and our very own no stranger to this organization or to talking on the behalf of GO2 and or people living with lung cancer, Terri Ann DiJulio, who is a 17-year survivor, advocate, and GO2 Foundation National Ambassador Council member. So welcome to both of you. I think tonight, most of you have seen the topic and what we're going to be talking about, and it's really about understanding nodules, lung nodules. And I think a really important place for us to start is sort of this introduction to a nodule. What are they? What causes them? How do we monitor and treat them? You know, nodules are found during screening, early diagnosis, incidental findings, progression of disease. So we're going to dig a little bit deeper and talk about, how common they are and what causes them. So when we say something was incidentally found, I think we know when we're talking about screening, if something is found, then that makes sense. It was found through screening. When you've already been diagnosed and maybe your cancer progresses and a new nodule is found, that I think tends to make a little more sense. But when we talk about this incidental space, Dr. Lanfranco, can you just really quick give us a sort of overview of what we mean when we say that?
An incidental finding like a nodule is usually happening when you're getting a CAT scan for some other reason. So you go to the ER because you've got a fever and chills and are short of breath, and they do a CAT scan, looking for pneumonia, or you've got chest pain and they're looking for a pulmonary embolism. And we're doing more and more CAT scans now than we did, 20 years ago. And so we're finding all of these things that we didn't know about 20 years ago that people were walking around with. And we call them incidental findings. We sometimes call them incidentalomas, or just, things that we discover accidentally when we're evaluating other things.
Thank you. I think that's important because it's one of those sort of bites, I guess, that GO2 is really interested in pursuing and growing programs around these incidental nodules, because quite often those are ones that go missed for a potential lung cancer diagnosis. You're in there because you broke a leg, or to your point, somebody thinks you might have pneumonia. Good news is you don't have pneumonia. Bad news is you did have a nodule that nobody really picked up on, and you walked out the door sort of, without knowing really what was going on. So thank you for that overview. And now I'm kind of excited to jump into just sort of nodule 101. I think quite often in the healthcare space, particularly when we're talking to our patient community, either those at risk or those diagnosed, we tend to use words that we just assume people are going to understand, or that everyone's going to understand, that it's just a universal knowing, I guess, if you will. So as an interventional pulmonologist, what role do you play in screening, detection, and even treatment of lung cancer? And then we'll jump into sort of this 101.
So as an interventional pulmonologist, I'm kind of at the intersection of a lot of those things. So I am part of a lung nodule or lung cancer screening program. I am diagnosing lung cancers. I see a lot of patients that come, just like you mentioned, they go to the ER and they get a CAT scan and somebody didn't miss it, and they get sent to evaluate lung nodules. So really being a trained pulmonologist that does advanced diagnostics kind of puts me in this unique position where I'm oftentimes one of the first people that patients interface with when they have a lung nodule. It's not always that way. A lot of people can get in the door through thoracic surgery or through medical oncology, less often radiation oncology. But a lot of patients wind up coming through their pulmonologists and their pulmonologist. And so I'm kind of at that, right at the junction of where they all meet. Once a patient has lung cancer, I often try to function as kind of an advisor to help them get to the right places. So once we diagnose a lung nodule as a cancer, then I have discussions about, okay, what comes next? Do we talk to a surgeon? Do we talk to the medical oncologist? Do we talk to a radiation oncologist? Do we talk to all three? And really trying to help the patient find a treatment path that makes sense for their disease, but also for themselves personally and where they're at in their life.
I want to put sort of an asterisk and like an exclamation point at the end of your role in all of this, because I think far too often, particularly in some of the smaller community settings, the pulmonologist is sort of an afterthought, if you will, if it's even a thought at all, when we're talking about the team of healthcare providers that are looking at diagnosing and treating lung cancer patients. And it plays such an important role, not just during or upfront with screening and diagnosis, but to your point, in that sort of decision making process about treatment options. And then really, you know as an adjunct to that, just pulmonary health in general, right? We know that if somebody's diagnosed with lung cancer, there is disease in their lungs, thereby they need help from a lung specialist. And I think a lot of people sort of miss that and just assume, well, pulmonologists are the guys that if I or someone I know has asthma, for example, maybe that's someone you go see. But it's so much bigger. So hence the sort of asterisks and exclamation point. Okay, without any further ado, this lung nodule 101. When we say lung nodules, do they go by other names, for one? Because I think that's another mistake we make when we're putting information out there to the masses, is using multiple names that really mean the same thing. So what are lung nodules?
I like that you say that they're called different things because I hear lots of different things. So lung nodules, spots, growths, masses, all these words that can kind of get lumped into the lung nodule realm. Really, what lung nodules are, if you're looking at a CAT scan, we'll put up some CAT scans in a couple of minutes, but if you're looking at a CAT scan of the lungs, one of the things that's really apparent is that the lungs don't have much density to them. They're filled with air. And so if you have something growing there that doesn't belong, it shows up apparently as a density because cell growth is dense. And so that's typically what a lung nodule is. It's some type of cell growth. It doesn't have to be cancer, by the way. Some type of cell growth. It's just more dense than the surrounding lung tissue, and therefore we can see it on the CAT scan. That's sort of the basic premise of the lung nodule.
And I love that you said that not all lung nodules are cancerous, because I think, well, my personal opinion, take it for what it is. When I look at the current qualifying criteria for screening for lung cancer, we know we can do better. We know we need to expand that screening criteria. But even based on what we have now, a very small percentage of folks who currently qualify are actually getting treated. And I think there's this fear, right? Like, what if they find something? And I think it's really important to point out, particularly in the qualifying criteria like age range, nodules are not uncommon, even benign ones.
I like to tell folks when I'm first meeting them that, if I were to take 100 people walking off the street, maybe not right in front of where I work, but somewhere down the block, and I put those 100 people in a CAT scanner, 20 or 30 of them would have some form of a nodule, and almost none of them would be cancer. So that's especially true if you live in Philadelphia or other, post-industrial places. But they're very. And if you're in the Midwest, like the Mississippi River Valley, there's an endemic fungus there. Virtually everybody has a nodule there because of this fungus. So not all nodules are cancer, and I think that's really important to know. Because back to your point, a lot of people are afraid of getting screened because they jump to the conclusion that if they have a lung nodule, they have lung cancer, and that's not necessarily true.
Yeah, agreed. And I know, Terri Ann, once we kind of get through what lung nodules look like, what the differences are, I'm really excited for you to share your story and from your perspective, because I know you've had a lot of monitoring and following up and the fear that's sort of associated with that. But before we jump into that, we know what a lung nodule is, right? It's an abnormal spot, for lack of a better term, or just to keep it simple, that's on the lung that is found typically during a CAT scan. So now we've identified a nodule. What are we looking for when we're viewing the nodules? We know they're not all alike. So what are some of the differences that we see in these lung nodules?
What I'm doing when I'm looking at a lung nodule is I'm trying to figure out the probability that that lung nodule represents a cancer. And so essentially what I'm doing is pattern recognition. And so the patterns that I'm looking for cancer are things like size, whether the edges, what the edges of the nodule look like. So lung cancers especially are usually what's called spiculated. So they've got sort of these tendrils that come off of them and stick out into the surrounding lung. We also talk in terms of margin, we also talk about lobulated or smooth, and that can give you clues about other processes that can be causing the lung nodule, whether that's an endemic fungus or whether that's a cancer coming from somewhere else in the body. Those can be clues. The density of the nodule is important. So the way that x-rays work is it really is all about density. So you can have nodules that are very dense, and you can also have nodules that aren't dense at all and show up as ground glass, which doesn't mean you have ground glass in your lung. It's just some guy back in the day was describing CAT scans that thought it was, looked like if you ground up glass and tried to look through it. And then there's benign tumors too that can have like less dense centers to them. They can actually have what we call fat density. So, fat in your body has a specific density on CT scans. And sometimes nodules will have fat density in them. And that's indicative of a benign growth in the lungs. And so density is also very important. And then in addition to, size, knowing what it's doing over time. So a lot of times if a patient's coming to me the first time, with a CAT scan, I'm actually looking back at old scans to see if there was something in that spot before. If you had a scan 3 months ago and there's nothing there, and you have a scan, today and there's a big nodule there, it's probably not cancer. Cancers don't usually grow that fast. But if, you come to see me and you've got a nodule on a CAT scan you had today, look back, 2 years ago on a CAT scan of your belly that happened to pick up part of your lung, and I see a tiny nodule there that nobody saw, nobody noticed, then I'm more suspicious, and the probability of a cancer climbs, it goes up. So I'm going to be more concerned.
So I just want to kind of recap what you said. So we've decided what lung nodules are, and I'm restating all this because I think it's so important. There's such a misconception about their abnormal spots in the lung, not always cancerous. Some are non-cancerous. Lesions, spots, growths, nodules, tumors, and on down the road. When we're looking at and viewing nodules, there are 4 sort of main things that your healthcare provider, such as a Dr. Lanfranco, radiologists, and others may be looking at to determine what next steps will be, right? So we're looking at the margins, as he explained, the spiculated sort of spiky ones, smooth and lobulated. Density, like what does that lesion look like? Size, how big is it? And consistency, so the ground glass part. And I loved your, I guess I never really thought about where ground glass came from, so I appreciated your description of it. Part solid or solid. So those 4 things often, if I'm correct, lead you to what are next steps? Because we know next steps are sometimes we go to a biopsy and sometimes we just go to monitoring and follow up. So what else might you be looking at, or how does that decision made? Is it really just based on those 4 things, or is there larger conversations? I don't know the answer to this, which is why I'm asking.
What those 4 things help me discern the probability of a lung cancer. And as the probability of a cancer increases, the more likely I am to recommend some intervention. And I know we're going to talk about interventions in a little bit, so I'm going to leave that on the table for now. But that's really what I'm trying to do. Is I'm trying to pin down what the probability of cancer is. And if the probability is high, we're going to act, we're going to do something. If the probability is low, we probably won't do much of anything. If the probability is somewhere kind of like, I'm not sure, but it's, relatively low, we're just going to watch.
That's great. And I think what I'd like to do now is maybe bring up some of those slides one at a time so we can get sort of a visual. And if you can kind of describe where in the lung or where in the image we are looking and what we're looking at, I think that might be helpful for some of these folks.
Yeah, great. So right in the center of this CAT scan is a lobulated nodule. You can see it's surrounded by lung. The lung is all the dark, sort of hazy stuff, and there's little white dots and squiggly white lines, which are blood vessels. And then on the right, you see there's some white, sort of almost oval or oblong shaped things. Those are ribs. And then bottom left, white thing is a vertebral body, so backbone, basically. Now this nodule right in the middle is sitting at the very bottom of the left lung. And I would describe this as a dense nodule, and I would call it lobulated. So you can see that it's not perfectly round, it's not spiculated, so it doesn't have a bunch of tendrils coming off of it, but it's got sort of these lobes on it. So if you look at the sort of the left-sided aspect of it, you'll see there's kind of a lobe there, and then as you go around the edge of it, you'll see there's like these little sort of rounded protrusions that come out of it. And so that's a lobulated nodule. This is probably a metastatic thyroid cancer, actually. So just to give you a sense of what these nodules are, if I know what the answer is, I'll tell it to you. This is a cross-section through the bottom of a patient's chest. On the left, you have the right lung, because we're sitting at the patient's feet looking up towards their head. And on the right side of the screen, you have their left lung. So it's a little bit confusing. Again, you'll notice the lungs are mostly dark because they're mostly filled with air, and lung tissue itself is not very dense. Lots of little dots, little white dots, those are blood vessels. In the center of the lung, on the right lung that's on our left, sorry to be confusing, but in the center of that, you'll see there's this round, sort of hazy nodule or finding, and in the very center of that is another sort of solid looking dot. So this is actually something called adenocarcinoma spectrum lesion. Sometimes people call these part solid, mixed attenuation nodules, several different names to them, but this is a nodule that is highly suspicious for a type of lung cancer. And this patient was referred to surgery because the probability is so high. And this one, if you look at the edges of this nodule, you'll see that it looks like it's got little hairs or spikes sticking out of it. That's a spiculated nodule, and this is in the bottom of a right lung. This person also has a lot of emphysema, and their emphysema makes them not a surgery candidate. And so we're looking to treat this with radiation.
Hopefully that was helpful. And the nodules found, some of the above 4 sort of criteria determined. At what point is the determination, follow-up, and monitoring versus going straight to something like a biopsy? And then I'm going to ask Terri Ann for you to jump in, because I know this has been a decision point for you on more than one occasion.
The decision to do something can be a complex decision, and there's lots of different variables that play into that decision. Nodule growth, nodule density, what the margins look like, just like we've been talking about. All those things play a role. And then what's also really important is the time, if the nodule changing over time and how much time. And there comes a point when the probability of cancer just gets to a point where you have to do something. If it's high, we'll talk about biopsy in a second, but if the probability is low, I think we wanted to talk about this. The probability is low, we oftentimes recommend monitoring, and those follow-up scans are really important because, like I was just about to get into, change over time helps us decide how aggressive to be with a nodule. If you've got a nodule that you discover, and the doc says, you know what, I'm not sure what this is, but I'm concerned. You need another CAT scan in 3 months or 6 months. That's not a finding that you want to say, it's probably nothing. I'll come back in a year, because in a year that thing can be much bigger and it can actually change your treatment and your prognosis significantly. So it's really important, if you're given advice to monitor a nodule, to follow up on that advice.
I think this is where Terri Ann comes in, because I really think this is an important place for you, Terri Ann, to talk about how exactly what Dr. Lanfranco is talking about right now has impacted this process for you, from going from monitoring to, okay, now we need to do something. And I don't want you just to share your story, if you wouldn't mind. Talk a little bit about maybe some struggles that you may have had with uncertainty and worry that comes with the waiting part. 'Cause I think a lot of times it's hard for folks to say, okay, I just want to go ahead and watch and wait, instead of, no, 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 I want you to get in right now and see what it is I'm dealing with. So I'm going to turn over to you to share your experience with the community.
I think what Dr. Lanfranco said about following the advice that you're given is critical. Had I not done that 19 years ago, my outcome could have been completely different. So even though I was technically diagnosed 17 years ago, I was 42 years old. They found an incidental pulmonary nodule in the emergency room. I was admitted to the hospital because more for my heart. No one thought this thing in my lung was anything. So after a few days in the hospital, I'm released. They say, we want you to watch this. Come back in 6 months. And I'm glad I did. We watched it. I got scanned every 6 months for 2 years. At the 2-year mark is when I was told, if nothing's changed, I'd be released from my pulmonologist care. At that time, I was going to a different pulmonologist. But at the 2-year mark, my tumor changed and it grew and it became more dense. And I was sent to a thoracic surgeon. And I think the reason that my first nodule was a wait and see is because no one thought, even when I went into surgery, that this was malignant. They thought it was most likely benign. So they were going to wedge it out, biopsy it while I was on the table, and if it was malignant, they would remove the lobe of my lung. So I woke up without the lower right lobe of my lung because it was malignant. From there, I was watched. So first it was 3 months, then it was scanned every 6 months, and then after 5 years, it went to every year. And I'll say during this time, my mother was diagnosed with lung cancer in an identical way. She went to the emergency room with chest pains. They found her lung cancer. They found a tumor. Only hers, they acted on right away. Hers was stage 3. So, and I'll just want to add this part of my story because it's pretty miraculous for the rest of my family. She told her doctor about me. And my case was unusual because of my age. We know that that's not quite as unusual as today as it was 19 years ago. So they recommended that the rest of the family be screened. And we then later found out her sister and her brother also had lung cancer. So after that experience, then, my sister and I helped my mother go through her treatment plan. And I was still being scanned at this point every year. So my pulmonologist left clinical medicine, and my uncle was going to Penn to Dr. Lanfranco, and he recommended that I go see him. And now at this point, I'm on annual x-rays. So Dr. Lanfranco orders a CT scan, because what I did learn is you can't really tell from an x-ray as well as you can from a CT scan. I think it's very important for people to know that for your own advocacy purposes, ask for CT scans. So my very first meeting with Dr. Lanfranco, he had the pleasure of telling me I had lung cancer for the second time. So there was a spiculated nodule in the lower part of my right lung. So that was a little nerve-wracking because I went to a surgeon And even though it was a small tumor, because of where it was located, the only surgical option was to remove the rest of my lung. And because I learned that the middle lobe can't survive by itself. And I'm really active and fairly athletic, and that really wasn't an option. And my particular tumor, we felt confident, or Dr. Lanfranco felt confident that it was malignant. So after several conversations, the decision was made to have radiation. So I had SBRT radiation on that tumor. So they couldn't biopsy it either because the risk of biopsy outweighed the benefit because they were so certain that it was malignant. And then from there, I was back to a 3-month follow-up and then a 6-month follow-up. And I've never gone any longer than 6 months in the past, I'd say since my second diagnosis. So then 5 years after that, now we discover something else that's on my left lung, which I say my good lung. And so we watch it. And when you talked about the uncertainty part of it, it never goes away. It's always there. And I'm an action-oriented person, so I like when we can come up with a plan. If we have enough information that we can come up with a plan and do something about it. But when we're not sure what it is, and we have to wait 3 months, see if it's changed, wait another 3 months, it's not really where we want to do anything with it yet. You know, that's really unnerving for me. And I've learned to just look at it and realize that worrying about it isn't going to change the outcome. We still don't have enough information to make a decision. The best decision is to wait and watch. So I can sit around for the next 3 months and worry about it, or I can just go live my life and worry about it when I need to worry about it. Right now, I'm not going to treat it. So we did that for, I think, 3 scans until it got to the point that everybody felt that something needed to be done. I did not want surgery 18 months ago. And I was absolutely sure I was not going to go and have surgery because 18 years ago, it was really hard and it was really painful. And I had 2 surgeries. I had one that they found a malignant tumor, and the next year I had the exact same surgery, only thankfully it was benign, it was scar tissue. But it was a really hard, difficult situation. So I didn't want to have surgery again. And Dr. Lanfranco was my coach. You know, we talked about, there was ablation, there's radiation. I voted for radiation. I wanted radiation because it was so much easier 5 years ago. I was tired, you know, for a couple of days, 10 days afterwards, that I could deal with, right? You know, they keep cutting away at your lungs. It's precious real estate. I wanted to keep it as long as I could. So surgery was not my first option. And Dr. Lanfranco encouraged me to keep the door open to surgery. So I went and I spoke to my medical oncologist and I got his point of view. And then I spoke to the radiation oncologist and I got his point of view. And I spoke to another doctor. I'm not really sure what his overall role was, but that was about ablation. So like there were all these different treatments that I could have. And I took all the information and that I obtained, all the answers, and I met with Dr. Lanfranco and made the final decision with him. But walking in the door saying, okay, you were right. Surgery is really the best option for me. And I ended up having surgery 18 months ago and had a wedge resection of my left lung. And it was a pretty incredible experience. I also got to participate in a clinical study during that surgery. And because of that, they found a second tumor, which was technically my 4th malignant tumor that didn't show up on any of my CAT scans. So, and they were able to remove both tumors, both nodules, in one wedge resection, and it didn't really impact my lung capacity, which was really important to me. So it's really hard and it's emotional and it can be frustrating to wait and see
Yeah. So Terri Ann, I just want to recap and with a couple of takeaways. I mean, I think you did a good job describing, sort of the transition through this monitoring 3, 6, 12 months. And I know speaking with a lot of folks who have been diagnosed with lung cancer who are also, and even those who have been screened but are still in this monitoring process, the anxiety that comes with the extension, I guess, of the follow-ups. Like, oh, okay, well, are you sure we can go to 6 months now? Are you sure we can go to a year now? Because what if you put me on a year and 6 months from now and then there's something anyway, you know what I'm saying? And so I think there's a ton of anxiety that comes along with that, number one. Number two, you talked about the different surgical experiences you had. And I think it's very important for folks out there to know, not only in lung cancer in the last 15 years in particular, have we made huge advancements in the treatment realm, but in the technology realm as well. And so where 15 years ago plus, the majority of lung cancer surgeries were done through like a thoracotomy where they're cutting halfway across your back. Now with the assistance of video assisted thoracic surgery and or the Da Vinci or robotic assisted surgery or anything like that, I say turnaround time, and I mean turnaround from you going in, having your surgery and being back up on your feet is so much shorter. So I think it's always important to keep up with what's happening, not just from a treatment, from a drug standpoint, but from how we're monitoring, how we are discovering, to your point, that study that you and Dr. Lanfranco made the decision together to not only am I having, this surgery, but I want to enter this study, and lo and behold, here's this other nodule that we wouldn't have found. That's it. Those are all advancements that are benefiting you. Because I know you to be a very educated patient. You are someone who, took the bull by the horns from very early on and decided you weren't going to let this cancer control you. You were going to control it, and you were going to make decisions, and you were going to pull together teams to make these decisions with. And I guess my question is, not only how important is that to you, and has it been in your experience, but how important is it for you to share your story with other people in hopes that they will also educate and empower themselves so they can make these informed decisions?
It's very important to me. I will say one thing though. I will make one correction: is I don't think I control the cancer. I can only control how I react to it, and how I react to it is knowing everything I can know about it. And I do encourage people to be their own advocates and speak up. And I'm not just saying this because you're on the call, but my medical team is amazing. I ask a million questions and run through a million different scenarios. And for me, it's very important to understand because everybody's invested in the outcome, but no one's going to be as invested in my lungs as I am, and so I want to know everything there is to know. I want to ask a lot of questions. Um, I want to understand what the best treatment options are. So I encourage patients to get out there and talk to their doctors, educate themselves. And it's so different now than when I was first diagnosed. I wasn't worried when I was first diagnosed. I didn't think there was anything to worry about until I was actually diagnosed with lung cancer. And then I went on the internet and I was paralyzed because there was nothing there for me to find. And my doctor said, get off the internet. You're not a statistic. And the statistics for lung cancer 18 years ago, I wasn't going to be here. you know, Early detection is key. So I also encourage people that are afraid to go and get scanned to talk to them about getting scanned because, I have a great life and I've had lung cancer 3 times. And it's because it was caught early and treated. And it doesn't have to be the death sentence everybody thinks it is. If you can catch it, the earlier you can catch it, the better it is. So I speak to patients and I talk to people, A, for awareness. It's really important to me. And B, I want to show them what's possible. And I'm just so grateful for where I'm at And I'm so grateful for my experiences. And I want other people to have this experience. And there are more of us out there to be found. And I want to help find them and let them have great outcomes too.
Yeah. Thank you, Terry. And I appreciate that so much. And I think it all points back to educating and empowering yourself and finding amazing healthcare teams and multidisciplinary teams that will work with you on that shared decision and decision making. And for those of you who may not know what we mean when we say that, it's you understanding what your options are and having the conversations with your healthcare providers about what the best options are for you. So, and there's a risk reward sort of piece to all of that, right? These are the benefits of doing it this way, but these are also the risks. And you being a part of that decision making, I think, is a whole lot easier when you're somebody who's actively involved in not only the diagnosis but the treatments that follow. And this is where I'd love to hear from Dr. Lanfranco, because I too have a very strong family history of lung cancer diagnosis, all on the maternal side of my family, straight up to my great grandfather. Can you talk a little bit about that? I mean, and that's a big like light bulb sort of bubble where I think a lot of people are having conversations, but really haven't identified what the tie exactly is, similar to what we find maybe in like a BRCA gene. So if you can describe that a little bit.
The genetics in lung cancer and inheritance are murky, to be very precise, murky. Well, let me just say, it's not like inheriting the BRCA gene or inheriting blonde hair, or blue eyes, or anything like that. It's much more complex, and it's probably more along the lines of inheriting a predisposition for lung cancer. So there's something in the genetic code of these families that predisposes them to developing cancer if they encounter the right trigger, cigarette smoking, say. That's the most common. And so we find that lung cancers do travel in families. It's usually associated with smoking. So if you have a relative who has lung cancer and you smoke, you're more likely to get lung cancer. It doesn't mean, though, that if you have a relative that has lung cancer and you don't smoke, that you're likely to get lung cancer. It doesn't travel like that. You have to have that extra insult.
It's so interesting because I know talking with folks over the last couple decades, and one family in particular, I think there's this whole group of people out there that are like, well, what about me, right? Because I am the sixth person in my family to get lung cancer. We're never smokers. We don't live in Philadelphia, where there's all this like why us and what about us? And I think, when I look at it like that, and there's been some research, but I think it's another opportunity for discovery so that we can figure out for the sort of what about me, group of folks who do wind up diagnosed. They think they've done all the right things. They live this healthy lifestyle and, they get lung cancer.
That's a hugely important topic. So two points related to that. One is 15% of all lung cancers happen in never smokers. But the public policy is really a result that most lung cancer victims are smokers. And so there's this stigma associated with it, which is tragic and stupid and means that there hasn't been the appropriate amount of research dollars pumped into lung cancer, despite the fact that it kills more people than any other cancer out there.
Yeah, this is such a sticking point for me, and it's one of those things that makes like smoke come out of my ears because no literal pun intended. But I think, you look at just lung cancer in general, number one cancer killer, never smoking lung cancer, in spite of that 15% number, is still a lot of people, not just nationally, but globally. And it's still number 5 in the list of cancers for top killers. And so, unless that data has changed since I last looked, which was probably, I don't know, couple of years ago. But the number 5 top cancer killer is never smoking lung cancer. And the fact, and this is where this outrage, where I think we've done a lot of great things, but where this outrage kind of stems from how have we let it go this long without directing the dollars towards a better understanding of this disease? And now it's finally happening, and we're here. And I can quit my rant because I'm also watching The Time. And I know we've talked a little bit about determining when a biopsy should be done. One of the things we didn't jump into are the multiple sort of ways with which that biopsy can be done. So can you, Dr. Lanfranco, give us a high sort of overview of some of the different options for biopsy? Because I think people are also afraid of this procedure as well.
I will say that for most people, that these diagnostic procedures wind up being a distant memory. So even though they're scary when you're approaching them, 5 years afterwards, you're like, oh, did I experienced this. Oh, you did a biopsy on me 3 years ago? I don't remember. So it happens that people forget about it. It's scary when you're confronting it the first time, but it's part of the process, and usually it goes smoothly and people tolerate them well. So if we're talking about lung nodules, there's really 3 ways to get tissue. And in lung cancer, tissue is imperative, especially now, because we need to know the genetic markers of the tumor. We need to know its immunophenotype, meaning how does that tumor interact with your specific immune system. And we need to have enough of that material to do, it's a stunning number of tests we run on that tissue. So being able to get enough tissue and provide all this information is part of the decision-making process of which biopsy to pursue. But generally, there's 3 ways to get tissue from the lung. And which way we go is determined in a lot of ways. One is overall or underlying lung health, accessibility of the nodule, and whether a person would tolerate surgery or not. So 3 ways are: 1 is a transthoracic needle biopsy. So that's where you see a radiologist or an interventional radiologist. They usually lay you on a CAT scan table and they numb up your skin and they put a needle from the outside into your lung, into the nodule, and they collect material to send to pathology. The second way is bronchoscopy, and bronchoscopy is sort of a generic term. Under bronchoscopy, we talk about a lot of different technologies. At the core of it, though, bronchoscopy is really just a scope like people get colonoscopy, or they get people looking in their esophagus. It's that same technology, it's just smaller, so it fits in the airways. So it's a long, skinny tube with a light and a camera and a working channel. And then we've got a scope that has ultrasound on the tip of it that lets us look outside of the airways so we can identify the structures in the middle of the chest and do ultrasound-guided biopsies. We've got ultrasound probes that are about the size of a spaghetti noodle that we can slide out into the lung to get pictures of nodules and help us direct our biopsies. We've got a variety of navigation devices that we can use. There's virtual bronchoscopy, which is just GPS for the lung. It just tells the doc where to turn and put the scope. We've got electromagnetic navigation, which is GPS attached to like this electromagnet that tells a computer where the nodule is at in space and where your instruments are at in space, so you have a more precise view and targeting of nodules. And then the most recent innovation is robotic bronchoscopy, which it's still just a bronchoscope. It's still just a skinny tube that goes down in your airways. But the way we control that bronchoscope is very different, and it's much more precise than the traditional bronchoscopes. So just to bore you guys with technicalities, so a regular standard bronchoscope is, the doc's controlling it outside of your body, just turning their wrist and pressing their thumb. But the robot actually is controlled inside at the tip using the robotic technology. So it's fascinating. It's also often coupled with other technologies. So one robot uses electromagnetic navigation. Another robot uses this light emitting diodes to do something called shape sensing, which is, the tech is unbelievable. And then we're actually also combining the robots with something called cone beam CT scanning. So we can actually do CT scans while we're doing the procedures to make it even more precise. So that's a very long-winded explanation of bronchoscopy space, but just it's all kinds of stuff that's out there. And then the third way to get a biopsy of the lung is surgery. And so just like Terri Ann's experience, if there's a nodule that's amenable to a wedge biopsy, they'll go in with they'll do a wedge while the patient's still asleep on the table. They'll take it to the pathologist. They'll do a frozen section. So they'll look at the tissue in real time. If it's cancer, they'll come back and do the cancer surgery, which is removing the lobe. If it's not cancer, they close and wake you up. So those are the three ways to get a biopsy. And the decision which path to take can be quite complex.
Yeah, it sounds very complex, and I too agree with you on the fascination piece around the technology. I've been following sort of the growth of this technology space for a long time. I have a dear friend who's an interventional pulmonologist out here in California, down in Mountain View, and with the permission of patients, of course, I've been invited into the sort of operatory and watched some of this happen in real time. And, fascinating doesn't even begin to cover it from my perspective. But I think when we really look back and think about it, and particularly with GO2, and one of our main goals is to increase the rates of people being properly diagnosed, including upfront comprehensive biomarker testing. The only way we're going to do that is to gain access and get access to quality and quantity of tissue that's appropriate for this testing. And so I am unbelievably blown away by the way that we can do this now. And we need to do it the first time, I should say that, because I know there's a lot of patients who have to go in for multiple biopsies because they didn't get the quality. It was either necrotic or dead tissue, or just we didn't get enough. And so I think this is, yes, I geek out on this too. So I'm right there with you. As always, you guys could please consider joining our patient and caregiver community. The URL is coming up right there on the bottom. This will really help us to remind you about this programming, so you can decide what you do and do not want to chime into live and or post live. Again, I want to give a huge thank you to our panelists, all of you watching live, or those who will come back and watch post live. Penn Media on the back end of this, is helping us to bring this programming to you. Michelle Zay, who's like the right arm of this programming, and is also on the back end monitoring every month, and the entire GO2 team really for all of their support and all of the work that they do for this community. And as always, our generous supporters: Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Janssen Oncology, Merck, Mirati, Novartis, Regeneron, Sanofi, and Takeda. Thank you for continuing to support this programming. And with that, we will hope to see you guys next month. Everybody have a great evening, and until then.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.